Hi everyone, thanks Elena and the organising committee for inviting me today to present. I love working closely with my New Zealand colleagues and I'm really happy that the nurse practitioner role is on your radar. Half the battle of the nurse practitioner role is getting buy-in from execs. So by me being here today, it demonstrates that you guys already have some support for the nurse practitioner role at some level, which is really great. So I'm going to talk to you today a little bit about the history of the nurse practitioner, the education pathway to becoming a nurse practitioner, the trauma nurse practitioner role itself, a little bit of evidence, a comparison between the clinical nurse specialist role and the nurse practitioner role, and a little bit of a comparison from the nurse practitioner role to the medical role as well. Keys to success for me and some barriers for me also, so I hope you enjoy. So a little bit of history. So the USA NPs came first, and there are lots of them. Australia and New Zealand followed in the early 2000s. In 2002, Dr. Deb Harris became the first nurse practitioner in New Zealand, pictured here. She's a neonatal nurse practitioner and a clinically focused researcher. But like in Australia, in New Zealand, I think people don't often understand what we do. And that's probably one of the reasons I'm here today. So I hope this clarifies a few things for you. The pathways. So we become a generalist nurse. We then decide that we'd like to specialise in whatever area that might be, and we need to get 4 years experience in that specialty before we can consider the nurse practitioner role. We also need to get a postgrad qualification in that specialty. You then need to complete an NP master degree while concurrently being supported by a health service as an NP candidate. And in that role as an NP candidate, you need to complete 300 clinical hours working as an NP, supported by a medical consultant from that specialty. So not an easy feat. So what do we do? The key for the nurse practitioner model is providing holistic care to our patients. We complete this through completing a thorough history and assessment of our patients. We can order and interpret investigations to go on and make a diagnosis. We can construct and implement a treatment plan for our patients and their families. This includes prescribing. We initiate and receive appropriate referrals from health professionals, including referring privately, which is great. The NP model is all about scope. So basically, I can order and prescribe whatever is appropriate for the trauma patient. The trauma patient is my scope. For Dr. Deborah Harris, her scope is any care that she provides to the neonatal patient. This is different from the medical model, which they have a wider scope depending on what role they're in at the time. But this is also why NPs are experts when caring for their patients, because their scope is clearly defined and they really become experts in the area. And this makes a real difference when if you work in a service like I do, where you have the junior doctors rotating through every 3 months. They've never worked in trauma before, never looked after a major trauma patient. So this is where the expertise care that the nurse practitioner can provide is really essential. The role aims to, and the evidence supports this, so we improve access to treatment. So most nurse practitioners have no wait times for clinics. We provide cost-effective care, so we are cheap, and I'll demonstrate this a little bit later. We target at-risk populations. We provide outreach services, lots of telehealth services. We provide leadership, mentorship, and clinical expertise to other health professionals. So in my role, I lead a team of trauma case managers providing mentorship every day. And I'm the lead nurse during the trauma ward round, providing expert trauma care, particularly to those junior doctors mentioned before that have never looked after a major trauma patient in the past. So my role specifically, so I'm a trauma nurse practitioner at the Gold Coast. I lead a trauma service and a team of high functioning trauma nurses who do an excellent job. Patients are in such great hands after hours and on the weekends when the rest of the team isn't there. We provide a 7-day cover AM and PM shift. Me specifically, so I lead the trauma ward rounds Monday, Tuesday and Wednesday, and lead the trauma multidisciplinary team meeting, which is weekly. and manage the follow-up for our trauma patients. So that attention to detail type stuff when you're making sure all of their appointments, their follow-up appointments are arranged, so referrals have gone in and the appointments are made, and then communicating that to the patient and their families. Also in that really good point of contact after discharge for the patient, so they can ring me and clarify any appointments or any issues they might be having related to their accident. If they're having lots of issues, I can then bring them back to my Trauma Connect clinic, which is an acute care post-discharge clinic where I see patients for analgesia weaning, complex wounds, persistent pneumothoraces, or persistent pleural effusions that need monitoring, that type of thing. So any acute follow-up review post-discharge I'll do in the Trauma Connect clinic, which is weekly. Also lead the post-splenectomy care, so making sure patients get their vaccinations and referrals on if needed, although we don't do many splenectomies anymore with the interventional radiology care that we get. And IVC filter removal as well, making sure all of those get done. More than clinical though, heavily involved in the system development and review of that for the health service, lead the quality and performance improvement program, lots of education, and sit on the board of the Australasian Trauma Society. So a wide and varied role, demonstrating that leadership, which is really important in the nurse practitioner role. So a little bit of evidence. The USA has published a number of studies evaluating the nurse practitioner role, and they've shown that trauma nurse practitioners offer a clinically effective and resource efficient alternative to residents on a trauma service. Looking at a level 1 trauma centre, trauma nurse practitioners improved the quality and reduced the cost of care, resulting in increased value at a level 1 trauma centre. And they showed that trauma nurse practitioners improved physician and nursing staff satisfaction with reduced length of stay and cost-effective care at another level 1 trauma centre. So you can use this evidence when you're looking at putting together business cases and things. I just wanted to do a bit of a comparison now between the clinical nurse specialist role and the nurse practitioner role. So to compare the roles, I thought I would look at the types of reviews we do. So the first review might be when we go and see the patient day 1 of admission and complete a trauma tertiary survey, then just during a routine ward review, and then in the outpatient setting. So clinical nurse specialists provide expert care to their patients. And if they've complete the competency, they can go on and complete a trauma or tertiary survey on their patients, usually done day 1 or day 2 of admission, depending on the status of the patient. If they have any positive findings from the tertiary survey, they can report those findings to the medical officer. They then rely on the medical officer to order investigations or to investigate that positive finding. And then they rely on the medical officer to refer to other medical specialties if needed to update the management plan for that patient. As a nurse practitioner, I can go and complete the tertiary survey myself, as the clinical nurse specialists can. But if I have any positive findings, I can order the investigations myself, interpret those, make a diagnosis and refer on to a specialty if required, or formulate a revised management plan depending on what the positive finding is. So you can see there the difference in scope for the 2 positions and how the nurse practitioner role can add value. The patient review example now. So we can both go and complete a head-to-toe assessment during a patient review, look at the images that have been complete that day, assess their pain. The clinical nurse specialist can review the prescription and refer on to the medical officer if they think some changes need to be made if they think the patient is under analgesed. They can assess their VTE risk, and if they think there's a deficit in their VTE prophylaxis prescription, they can talk to the medical officer about that. Also look at their wounds. Trauma nurses are really good at dressing traumatic wounds. And if there's any outstanding wounds that need washout or wound closure, they can refer that on to the medical officer to action. As a nurse practitioner, I can go and complete the head to toe assessment, do the image review, assess their pain, and if I think that they're under analgesed, I can prescribe as appropriate. I can assess their VTE risk, and if there's a deficit in their VTE prescription, I can prescribe as appropriate. I can complete wound reviews, do their dressings, and if there's any washout or wound closure required, I can go on and complete that myself in the ward environment. So again, differences in the scope there and how we do things. The follow-up or outpatient role of a nurse practitioner is a really good example of how the extended practice skills come into play. So I can autonomously lead an outpatient clinic. I can order follow-up imaging and pathology for that patient in clinic and manage their whole episode of care. I can manage analgesia weaning and provide updated prescriptions for that, assess any ongoing issues and refer on if needed. And if a patient needs readmission from outpatients, I can go on and organise that as well. I had a patient that came back to outpatients, was monitoring a persistent pleural effusion. Pleural effusion got bigger, needed draining. I spoke to the consultant about admitting the patient and went on and organised the admission for that patient. Good use of the nurse practitioner role while the other doctors are, doing their core business in theatre or whatever else they were doing at the time. So the question should not be what does one role do that the other cannot. The question should be how do the roles complement each other. Because when you truly think about that comment and think about the two roles in the patient context, like I've just explained, the answer to me is pretty clear. And it'll become clearer for you guys too. Some of the roles will overlap depending on how you design it. And the same goes for the nurse practitioner versus the medical role. Some of the roles will overlap. You just need good role delineation for the types of patients and the type of service that you have, but it can be done. Keys to success for me. So when you're developing a nurse practitioner model, you as a nurse practitioner need to lead the change, and you need to be determined to do that because there will be hurdles. No one else is going to do that for you. You need to show the value add. So one of the value adds for me was in the outpatient setting because I identified a gap in service. And a nurse practitioner role was a really good, cost-effective way to fill that gap. And you demonstrate that by using the evidence, and the evidence is out there. You show the savings, and I'll discuss that next. You need strong support from nursing exec. And remember that the key people to the success of the nurse practitioner role can also be your barriers. So you need to think about the language that you use when you're trying to sell the role. Medical support is often easy to get because as a nurse practitioner or a nurse practitioner candidate, you're working with these consultants day to day, so they see the value of the extended scope that the nurse practitioner can offer. So often medical support is easy. Think about who you're selling the role to. So you need to change the language depending on who you're talking to. So if you're talking to nursing or medical exec, you need to use the evidence, talk about the patient outcomes. If you're talking to finance, you need to talk about the dollar savings, and I'll talk about that a little bit more now. The fact that I'm here presenting to you guys now tells me that you already have some support, like I mentioned earlier. So you're halfway there. So the case for change, let's look at some cost savings now and compare the NP role to the cost of a consultant role. So nurse practitioners considerably manage high volume, low complexity end of a specialty. The evidence has proven this. And outpatients is a really good example of this. By the time they're getting to discharge, their complexity is much more lower. They're safe for discharge home, and they're a prime patient for the nurse practitioner to be managed or to be managing autonomously. And by a nurse practitioner doing this, you'll free up the specialist to manage the more complex issues for patients, for example, being in theatre with the fresh trauma patients that have just come in. In Australia, the dollar benefit is the same whether a nurse practitioner or a consultant sees the patient in the outpatient setting. However, the cost for a consultant to see the patient is much more. So you can see the cost saving here. So let's have a look at this. So the benefit, whether you see a nurse practitioner or a consultant in Australia, the hospital will get the same benefit. Okay, the rebate is the same. However, if you look at how much a consultant gets paid and how much a nurse practitioner gets paid, it's much more cost effective for the nurse practitioner to see that patient than it is for a consultant to see that patient. So you can see the cost saving, freeing up the consultant to go and do their more complex work. This is just another way of looking at this, another example. So first of all, let's compare the CNC, we call them clinical nurse consultants in Australia, versus the NP. The CNC is cheaper to employ than a nurse practitioner, but they don't generate the same amount of revenue that a nurse practitioner does. So a lot less, more than half. Well, a nurse practitioner generates more than double than a clinical nurse consultant does in the outpatient setting. But then if you go on then to compare the nurse practitioner and the consultant is much more expensive to employ than a nurse practitioner. But in the outpatient setting, they generate the same amount of revenue. So you can build this into the business case and show the cost saving. Again, freeing up the consultant to go and do the operating and do all the more complex work that they need to be doing. With every role development or system change, there's always barriers, but with that comes lessons learned, and I have a few. Role delineation is really important. So look at the patient cohort that you're trying to look after in your model of care, and look at the role delineation. For me, the barrier was nurse practitioner versus medical, not nurse versus nurse. So I've had to spend a little bit of time on that. And with that, I have to educate. So the junior doctors rotate through every few months. So I'm continuously sitting down with them, explaining what my role is, what my scope is, what my extended duty capability is, and telling them how we can work together, basically. Think about the language you use. Start using the trauma nurse practitioner role, and I still struggle with this. I introduce myself to patients as the trauma nurse, where it should be the trauma nurse practitioner, because the roles are different, and we want to, I want to highlight that as a clinician. So that would be my advice to you guys. In summary, and I hope you've enjoyed my presentation today, and I hope the nurse practitioner role is a little bit clearer to you guys now. The trauma nurse practitioner role is evidence-based. We do make a difference. We are cost-effective. The clinical nurse specialist, the trauma nurse practitioner, and the doctors can live together. You just need to review your service, find the gaps, and find the best fit for the best position in those gaps, and use the evidence and show your cost savings. And hopefully all of that together makes room for a great nurse practitioner model of care. Thank you for listening today. I hope you have a great day at your National Trauma Nurses and Data Managers Day. It's been lovely to be involved, and I'm happy for anyone to contact me to ask questions about the trauma nurse practitioner role, the pathway, what I do. Come visit. I'd love to have you come on a ward round or something like that with me. You're always welcome. Thank you.